We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, HIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Jesse, you ready for another joke?
I'm ready.
All right. What's the difference between bird flu and swine flu?
Oh gosh, I have no idea.
So if you have bird flu, you need treatment. And if you have swine flu, you need ointment.
I love it. I love it.
Where's my drum sound? So Jess, in this episode, we're going to talk to Lisa Sturm about her article in the latest issue of HIC. It's titled Impact of COVID-19 Pandemic on Hospital-Onset Bloodstream Infections at a Large Health System. So I'm going to tell you a little, it's pretty cool. I'm going to tell you a little bit about Lisa first. So she has been in the field of infection prevention for almost 30 years. She's certified in infection prevention, and she is a fellow of APIC, which is, of course, the Association for Professionals in Infection Control. She is active at the local and national level with APIC. She joined her APIC chapter, which was then called APIC Greater Detroit, in 1992 when she was a graduate student, where she then knew she wanted to be an IP when she grew up. She is currently the chair of APIC's Public Policy Committee and legislative co-chair for APIC Great Lakes chapter. She is widely published in numerous peer-reviewed journals, is the author of infection prevention chapters and books, and has presented internationally on infection prevention. Her most recent research is centered around the impact of the COVID-19 pandemic on healthcare-acquired infections, and has recent publications in infection control and epidemiology, as well as HIC. Lisa currently works at Ascension and is the senior director of infection prevention. Ascension is a nonprofit faith-based health system that's in 21 states and has over 140 hospitals. There's approximately 165 IPs at Ascension that form a very tight-knit group called the IP community. Lisa is proud to represent such an amazing group of professionals who she feels have contributed significantly to the ongoing challenges of the pandemic. So, Lisa, welcome. We're glad to have you.
Thank you. I'm so happy to be here.
So, hey, start us off by giving us a little overview of the topic and what got you interested.
So we have been tracking hospital-onset bloodstream infections, which we call HOBSI at Ascension, for many, many years. Actually, I've been with Ascension almost 6 years, and they were tracking it before I even started working here. We track it through our clinical decision support software system, and we use the same kind of criteria that NHSN uses for MRSA bacteremia as far as defining community onset versus hospital onset. So during the pandemic, we started to see an increase in not just our CLABSI rates, which we've published on previously, but also in our HOBSI rates. And that led us to kind of the question, what patient population is impacted by these HOBSIs, and that's what resulted in the study. And so we utilized the clinical decision support software from 69 of our hospitals to do the analysis. And that's what we published in HIC.
Fantastic. So Lisa, can you tell me why you decided to investigate events associated specifically with Staph aureus, E. coli, Klebsiella pneumoniae, Pseudomonas aeruginosa, and Candida species only versus including all organisms?
Yeah. So, well, for one, it's based kind of on historically, that's what we've always done. So we have lots and lots of data, long-term data, like I said, well over 6 years worth of data on these 5 pathogens. We also feel that these pathogens carry the highest morbidity and mortality, and we wanted to exclude common skin commensals. So it just gave us an opportunity to kind of stay focused while recognizing these are the ones that probably have the greatest negative impact on our patient population.
And before we get too deep in the woods about this, I wanted to say I was surprised that your study saw a decrease in E. coli bloodstream infections during the pandemic. Am I reading that correctly? And if so, any insights as to how or why?
So we did see a slight decrease in the E. coli hospital-onset bloodstream infection in our non-COVID patients pre-pandemic to the pandemic, but it wasn't statistically significant. And actually, E. coli did increase in our COVID population during the pandemic relative to the non-COVID patients.
I see.
So, yeah.
I see.
So the rate of community onset didn't see much of a change, but the hospital onset did. Can you talk a little more about that and why you think that happened?
Yeah, this was actually kind of a surprise finding in the study. We didn't think we would see this, and it was kind of like a golden nugget of information. So overall, there was not a big change in what we call HOBSI, or community onset bloodstream infection, between the pre-pandemic and the pandemic. But when we fracture down in the pandemic, those infected with COVID versus those that were not infected with COVID, we saw that the COVID patients had much lower HOBSI upon admission. So these are our bloodstream infections that develop, 0 to 3 days on admission. So we started to speculate that perhaps this was because our COVID patients' baseline health status was different than the average, pre-pandemic patient population, and perhaps a little more healthy, if you will, aside from the fact that they had severe COVID infection resulting in admission. So that was where we landed on that. We were not able at this point to do any deeper analysis on it, but we just feel that those patients' baseline health prior to admission, prior to COVID, was probably healthier.
Interesting.
That makes sense. Yeah. And before I ask my next question, I do want to clarify, just for most IPs out there that are listening, probably are used to thinking of bloodstream infections in terms of central line. This is not necessarily central line associated, correct? This is just all bloodstream.
Exactly. Right. So this is like a lab ID, kind of similar to the MRSA bacteremia metric from NHSN. It is all cause. So, and that's something we did not collect with secondary sites of infection. So we can't say with certainty that these HOBSIs were from wounds or pneumonias. Anecdotally, we know in talking with our infection preventionists across Ascension that a fair amount of our COVID patients had secondary pneumonia or peripheral IV infections, things like that, but we don't have the data to substantiate that. However, it is all cause, correct?
Okay. Just wanted to clarify. So was there a higher mortality rate in those patients that developed hospital onset BSIs or HOBSIs that also had COVID?
So we did not evaluate mortality as an endpoint in our study, but we do know from other studies on Staph aureus bacteremia that it has a very, very high mortality rate. Some reports as high as 30 to 39%. So we do know the impact, and that it very likely could have contributed to our overall COVID mortality statistics. Other researchers at Ascension have published on our mortality rates during COVID, and they ranged, depending on the time period, as COVID progressed, healthcare learned better how to manage the infection, and our mortality rates declined over time. But our mortality rates ranged from 12 to 19% throughout the whole period of study.
Wow. Okay, great. So one of the other pieces of data that was included in the study that I thought was interesting was that the hospital onset bloodstream infections were higher in the larger hospitals. So it seemed like, it was an incremental increase in the numbers. Why do you think that is?
Yeah, and that is very true. And we saw the same with the mortality study, saw the same. So we think it's because our larger hospitals bore the greater burden of the COVID admissions. And when we broke down hospital bed size by percent admissions, it was correlated. So the larger hospitals, because they're the tertiary care centers that could provide the ECMO, the advanced critical care needs of the patients, we just felt that they probably bore the larger burden of the COVID surges.
Yeah.
Yeah. And in that respect, do you have any idea on what staffing ratios were for the hospitals involved?
We do not. I do not have that data. I mean, we know that, essentially like all healthcare systems in the world struggled with staffing ratios and did their best to maintain the best they could at the bedside numbers. But I don't have the data to correlate with the percent COVID admissions or the HOBSI rates.
So along with the, issues with staffing ratios in the hospitals, we also know that there were universally accepted best practices that may have slipped during the pandemic. Do you have any areas that you'd like to highlight that you think could have contributed to the increased rates of HOBSI?
So, yeah, we have done a lot of kind of soul searching on this, as well as interviewing, our frontline workers and our infection preventionists across Ascension. So many things were impacted, not just the staffing, but also the environments where we were housing patients changed, but also the practices at the bedside as it relates to line care and vascular access, whether it was, extension tubing and pumps and halls, less rounding on devices, and also just less eyes at the bedside overall due to the circumstances of the patients in isolation and the early days of trying to conserve PPE. So there was just a kind of, I think, like the perfect storm. Things changed with, whether it's attendance to scrub the hub or maintaining, the clean, dry, and intact dressing sites and all the other variables. We also think there were some softer factors too, such as, we restricted visitors at the bedside. And oftentimes visitors are those patients' advocate that will say, oh, my family member's IV tubing just came disconnected, or their site is burning, or what's this redness here, or they're not acting right. Could they maybe be showing early signs of sepsis? So all those kind of soft and hard factors were probably contributory to the increase in the bloodstream infections.
It's interesting you mentioned the visitor limitations because we talked in a previous episode about the advocate often helping to decrease hospital-acquired infections for those very reasons. So it seems to be something that keeps coming up. I think that might be a topic that was underappreciated before.
Absolutely.
Yep.
So can you talk a little? Go ahead.
I was just going to say there's been other publications on the impact on outcomes by restricting visitors because they are another set of eyes and ears, and no one knows that patient more than a loved one or a family member that can, pick up on those little nuances that possibly, a regular patient care provider wouldn't recognize because they don't know the person's baseline.
Yeah,
so true.
A lot of patient safety stories and interventions come from family member experiences with their patients. So yeah,
sure.
Yeah.
There was one other thing that we heard quite a bit about, and that was, the central line bundle for CLABSI prevention, that also some components of that were sunsetted during the pandemic, such as, decolonization or chlorhexidine bathing, and some of the other routine practices that just in general reduce line infections might have had a spillover impact on our HOBSI rates.
Hey, I like you using the word sunsetted for that. That was very polite.
I use that word a lot.
I'm stealing it.
Rather than deprioritized.
Yeah, went by the wayside, tossed aside. So
just remember, things that are sunsetted, there's a sunrise, right? So that's where we're at right now, sunrising things.
I like the optimism. Yes, absolutely. So can you talk a little about how the length of stay changed during the pandemic and how that could have also affected HOBSI?
Yeah, so we know from our data that patients that develop HOBSI in general have an extraordinary length of stay, but we did not break that down for the COVID patients versus the non-COVID patients. But we do believe that the long length of stay, just in general, published on COVID patients, did definitely result in more device use, longer dwell times of vascular devices, and subsequently more likelihood of developing an HAI.
Yeah. And going along with that, in thinking about the length of stay, was there any data collected around the time of admission to the time of infection? Was that a short time period, or was it mostly for patients who had a significant length of stay that developed HOBSI?
Yeah, we did not collect that piece of information. However, that is something that we've been discussing as we continue to do this research about collecting that, because we do want to know, what is that sweet spot when the patient's increase of HOBSI goes up. So that's on our radar.
Awesome.
The paper mentions a lot of factors that kind of lead COVIDs to be at a higher risk, like, patients being in prone positions, comorbidities, or in some cases, hospitals had the IV pumps sitting outside of the room to prevent healthcare personnel exposure, et cetera, et cetera. So can you just talk about some of those factors?
Yeah, absolutely. So, when we saw the distinction in the HOBSI, like 3.5 times higher in the COVID patients during the pandemic versus the non-COVID patients, that then led us down this new path of, it's got to be the infection itself and what that circumstance is bringing to the HAI increase. So, we know these patients are on high use of steroids to treat the COVID infection. And we know steroids can suppress pain, inflammation, redness. So it's possible that the steroids masked maybe some signs of, let's say, a peripheral IV infection that was brewing at the site, where normally, the caregiver would notice redness and swelling, but the steroids were suppressing it, and therefore the infections, kind of festered. So that's one thing. Also, not just steroids, but all the immunomodulators to manage the patient's immune response to the infection. Of course, many of our patients, especially in the larger hospitals, like I said, were critically ill. We know our device days went up. We know we were using much more ECMO, where historically we didn't use that significant amount of ECMO on patients in the ICUs. Of course, ventilator use went up. As you mentioned, proning and what that does to secretions and dressings on lines, and just all the movement of the patients being turned over. And then, like I said, the patient's longer length of stay, the longer you're in the hospital, your chances of an HAI go up. So those are kind of like the intrinsic factors we think impacted the COVID patients. But of course, then there's all the extrinsic factors, which we just talked about, which was, the changes in the practice at the bedside and, sunsetting some of the CLABSI bundle tools.
Yeah. And again, something that it wasn't necessarily evaluated as part of the study, but was mentioned at the end was the patient's severity of COVID illness and other comorbidities that may have impacted the HOBSI numbers. I think that would be a really interesting criteria to use to stratify even further. But do you have any thoughts, any preliminary thoughts on maybe how that would have affected the data if you think that there were increased comorbidities in those patients or COVID illness, or do you think that wouldn't necessarily have been a huge factor in those numbers?
No, I do. I definitely do think the comorbidities, and we know from other studies that COVID caused a lot of, hyperglycemia and diabetic events. A lot of these patients went into renal failure, ended up on dialysis. And all those things increase your risk of bloodstream infection as well. So I definitely believe a lot of these secondary variables, the secondary pneumonia, bacterial pneumonias after COVID infection and being on a ventilator for such a long period of time definitely probably contributed to the bloodstream infections we saw.
Yes, super unfortunate.
Mm-hmm. Yeah.
And I want to switch gears just a little because we're so data driven. Let's talk about the standard infection ratio and how it became limited as a performance evaluator in this situation.
Yeah, absolutely. So, we've always, liked our SIRs. We've used them for years now, and they've been a trusted infection metric. But during the pandemic, the SIR is based off of 2015 NHSN baseline data. And the patient population, as we saw with our differences in our HOBSI and our HOBSI between the two patient population, was so different, just so different from 2019, let alone 2015. So we don't really feel that it was probably, a good risk adjuster for our COVID pandemic HAI data. And that's why we used, just the traditional infection rate per 10,000 patient days instead.
So as we think about moving, towards what we're referring to as the new normal with COVID numbers falling, hopefully, for the long term, what would you say you would predict to happen with HOBSI as far as do you think that the numbers will now start to trend downward as well? Or do you think this is highly dependent on some of those other criteria that we talked about, staffing and the sunsetting of some of those best practices that we need to sunrise again?
So we're actually seeing a rebound in our infection rates back to, more, I would say, pre-pandemic, not as low yet, but we see the trend going in the right direction. As our COVID census continues to fall. And also something that we haven't studied, but I have been thinking about is we know Omicron, the Delta, this data was partly within the Delta variant, but we know with Omicron, it was less severe, although it did cause a lot of hospitalizations. Those patients were not as sick as the Delta variant or the wild type strain. So we didn't see the infections go up as dramatically during the Omicron phase. We didn't see our device use go up as much because the patients were not all, is in the critically ill stage or in the ICU. So we are definitely hopeful that we will get back to, hopefully where we were in 2019 when we were really, really successful on reducing our HAIs pretty significantly. I think it's going to take some time, though, to sunset or unwind some of the practices that were put into place. But I know that people have a full appreciation for the fact that some of those practices were not safe. And it's time to kind of go back to our old standards for infection prevention and continue to track, because the data will tell the story, right? And, I always tell my infection preventionists that is let your data lead with your prevention. So I think we'll get there. I really do. As long as, we continue to move out of the pandemic phase and hopefully get into a more epidemic phase.
Yep. Well, Lisa, you're an optimist and a pleasure to talk to, and we're looking forward to a sunrise. So thank you for giving us some hope.
Yes, thank you so much.
Well, thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business. To hear other AJIC podcast episodes and to access information about this podcast in the field of infection prevention and control, go to our website at agicscienceintopractice.org. That's AGIC, scienceintopractice.org.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at AJIC and APIC staff, Lisa Tomlinson, Liz Garman, Bobby Gulshan, Chris Ruiz, Kelly Lynn Russell, Sylvia Quevedo, Kaylee Deaton, and Christine Miller. We work in partnership with Human Factor and audio tech Blake Alton.